Hello and welcome to State of the Economy. The NDA government is coming up with its full-fledged budget next month. Today we'll discuss what NDA has to offer in the healthcare space. The government is talking about a national health assurance scheme. What does this mean? Universal healthcare as a term has been bandied about for some time. How do we break down details of what universal healthcare constitutes? To discuss this in our studios, we have Dr. Srinath Reddy, who's President of Public Health Foundation of India. He also is a visiting professor at Harvard and has chaired expert panel of Planning Commission on Universal Healthcare. Welcome to us, Dr. Reddy. Also, we have Professor Dean Jamison, who's professor at the University of Public Health, Department of Public Health at the University of Washington. So I'll start with you, Dr. Reddy. What is national or universal health assurance, which the NDA government is talking about? What does that mean?
Well, universal health coverage or universal health care globally has now come to be defined by WHO as provision to all people of needed health services of quality with financial protection. That means without causing any financial hardship. So if we take that as the overall definition, then we are really looking at three dimensions of coverage. That is, what is the proportion of people covered by any program of health assurance or insurance or whatever we want to call it? And secondly, what are the range of services provided under that? That's the depth of services. And third, what is the degree of financial protection provided against out-of-pocket expenditure? So we would really want at least some of the essential services like primary health services, some of the secondary healthcare services, especially surgical services, and emergency services to be covered as an essential package which is available to everybody, free of cost. Then secondly, we would like to expand this range of services as we move along.
When you say everybody, it would cover the entire population?
Yes.
Irrespective of their income levels?
Well, the idea here is that primary health services at least should become part and parcel of everybody's entitlement. They include a variety of things, right, from immunization to a basic medical care, and of course preventive and promotive services as well. The idea here is that even those people who are supposed to be able to afford on the basis of their income have already contributed by paying their taxes. In a progressive tax system, the rich will subsidize the poor through their taxes, so they become part and parcel of the system. One of the reasons that it must be inclusive is if you actually have a program only designed for the poor, then the elite sections will have no stake in it, either in terms of quality or sustainability. It's only when they have also a stake in it, then they will ensure that it is of adequate quality and it becomes sustainable.
So therefore the logic of universality.
That's the logic of universality. Then the second element is we recognize that we will not have all services available to everybody from day one, but if these essential services are available to begin with, then we can start expanding the number of services covered in the package as additional resources flow into the health sector. But one of the important elements is financial protection. Right now, India has a horrendous level of 70% out-of-pocket expenditure, which is among the highest in the world, even compared to other developing countries.
Even privately paid
privately paid.
And also the draft says, the draft health policy 2015, national health policy of the government, says that average 70 to 80% of outpatients and inpatients are handled by the private sector. So, Professor Jamison, how does this compare with say other developing economies? You study all this at your University of Washington. So what does your research say?
Well, we see great diversity in all around the world in what fraction of patients are treated by private providers. So including in the high-income countries, places like Canada, Germany, patients are treated by private providers. The more essential distinction than the distinction...
Insurance.
the insurance is who's paying. Is it publicly financed or publicly mandated finance? And for the reasons that Dr. Reddy just went through, and Amartya Sen had a beautiful article earlier this month on the reasons for the universalism, as you put it, as an approach to financing these services. And that's the common element of the high and most of the upper middle income countries, and there's then great diversity in private versus public delivery of service.
Okay. So, Dr. Reddy, now, how do you go about universalizing health care? You said it has to be progressive. It ain't happening overnight. That we all agree, right? Now, do we have an optimal insurance design? We have a Bima Suraksha Yojana which claims, as per the draft policy, that it has increased coverage from some 40 million to 300 million over the last 10 years. Is there any outcome audit whether those 300 million who are covered are satisfied, or what sort of services are they getting? Is there any audit of supply? What's your sense?
Well, as you know, the Rashtriya Swasthya Bima Yojana was initiated by the Labour Ministry, principally to cover the workers in the informal sector, the unorganized workforce. And it is true that at a modest level of about 30,000 rupees coverage per family per annum, some level of secondary care services in the hospitalized institutional setting have been provided. And several people have benefited from those, though there has also been a major problem related to induced demand and problems of inappropriate care. Yeah. But the critical element of financial protection has not been achieved for the simple reason
we don't spend enough on health. We don't allocate enough on health.
Not only is 30,000 very modest for a family, the outpatient care and cost of medicines, which constitute 70% of all out-of-pocket expenditure, are not covered by any of the government-funded insurance schemes, be it the Rashtriya Swasthya Bima Yojana or state government-funded schemes. So
you're saying fundamentally we are not addressing the core.
We are not addressing the major problem of financial protection. No.
So then what are we talking about when we say universal health care?
So the insurance schemes as they are designed currently are not only
they have to be completely redone.
Not only inadequate, but they are also fragmenting the system. They are disconnecting primary care from secondary and tertiary care, and whereas primary care ought to play a very sensible gatekeeper function for secondary and tertiary care, this continuity of care is now totally disrupted.
So you're saying that Rashtriya Bima Suraksha Yojana does not cover tertiary care, secondary and tertiary at all?
No, it covers only secondary care. It doesn't, and only hospitalized care.
Okay.
It doesn't cover tertiary care. It doesn't cover primary care.
Okay, so it fragments the whole.
It fragments the system.
The system. Okay.
And
so what would you suggest to connect the system then?
Therefore, the National Health Assurance Mission, which is the new name for the National Health Mission, should provide all range of primary care services which are needed, connect them to hospitalized care under the Rashtriya Swasthya Bima Yojana with a connectivity brought about by a gatekeeper function. So you are actually providing, firstly, a safeguard against escalation of disease burden by tackling most of the problems in primary care. In fact, 90% of the problems can be tackled in primary care. Secondly, by,
as you said, the first 48 hours of birth.
Yeah.
It tackles a lot of problems. Yeah.
Tackles a lot of problems, and in fact most of the issues can be handled below the level of the district hospital. Then you add the district hospital to the primary health services, then 95% of the problems in that district can be handled. So by providing that connectivity and gatekeeper function, you can use the Rashtriya Swasthya Bima Yojana as a platform for secondary and tertiary care. Also, but you have to integrate it much more seamlessly rather than leave it afloat independently.
That means paying more premium. The government needs to fund.
The government definitely needs to fund more. There is no doubt about it, because if with 1% of GDP for the health sector, we cannot achieve universal health coverage.
So India would be probably among one of the lowest in the world at 1% of GDP.
It is
compared to other developing economies. Yes. Dr. Jamison, I mean, what's your?
It's startlingly low.
Startlingly low
relative to its GDP.
How do you compare it with, say, other developing economies?
Well, at the income level of India, you would expect something like 1.5 or 2% of GDP through the public sector. Make it clear, the total expenditures on health in India are not particularly low. So there's a very large volume of...
It's a government contribution which is very low.
Yeah, so India and the United States strike me as, well, you just had our president visiting last week with lots of similarities. A similarity that he didn't point to is, I think, in the structure of healthcare finance, where we have this same kind of problems of fragmentation of the system that Dr. Reddy just referred to. And in particular, we have an extremely high level of total expenditure on health, and relative to that total, a modest public expenditure. So we stand out among the high-income countries in the U.S. In a way that's quite similar to India, I think, among lower middle-income countries.
Okay. But then India and US, Dr. Reddy, are at two different stages of development, right? They're apples and oranges in one sense. At least the US healthcare, the Obamacare system does cover through private insurance, through government-funded insurance, where patients go to the private sector, private hospital. It's fairly wide, whereas in India, I guess we don't have anything, as you said. It doesn't cover primary and tertiary at all at the moment, right?
Well, the Obamacare, while it has brought in a considerable amount of relief to many Americans, is still a patchwork quilt of multiple insurance programs because they could not dispense with the pre-existing ones.
Okay.
And in India, even payroll deductions or employer-provided insurance or contributory insurance is going to be a problem because 93% of our workforce is in the informal sector, and many people are poor also and they can't afford.
That is the challenge.
So that is the
I
challenge.
think the bottom 700 million people are the challenge in
Are the
India.
vulnerable.
Yeah.
But remember that in terms of per capita public financing on health, we spend half of what Sri Lanka does, a fourth of what China does,
Even Thailand
and a sixth of what Thailand does.
my God, that's...
So at that level of public financing, we really cannot expect universal health coverage. That's why the national draft national health policy calls for at least 2.5% of our GDP to go into public financing. With that, we will be able to achieve a much wider range of services for a larger number of people.
Okay, okay. We'll take a small break here. Please don't go away and keep watching RSTV.
ये है बेलाडीला माइंस का इलाका छत्तीसगढ़ के दांतेवाड़ा इलाके में। सब जानते हैं कि यहाँ पर भारत के संविधान के विरोधियों का बोलबाला है। सीआईएसएफ के जांबाज जवान नक्सलियों के आमने सामने दांतेवाड़ा के बीहड़ जंगलों के बीचों बीच।
कई बार उन लोगों ने हमले किए हैं, कभी कन्वेयर बेल्ट को जलाया, कभी डंपर्स को जलाया, कभी हमारे आदमियों के ऊपर भी हमले किए हैं। उन सब गलतियों से हम लोगों ने सबक लिया है।
और एक नया जंगी दस्ता सीआईएसएफ के निंजा वॉरियर्स। राष्ट्रीय सुरक्षा का नया एपिसोड सीआईएसएफ रेड जोन के अंदर सिर्फ राज्यसभा टेलीविजन पर।
Welcome back to State of the Economy. Dr. Reddy, now you talked about a new design for healthcare in terms of insurance which is publicly funded. Can you give us some idea as to how this could work in the context of center-state relations? Because today what I see is that some states, India cannot be seen as a monolith. There are some states like the southern state which are doing much better than the landlocked Hindi heartland states where the bulk of the healthcare problems exist, right? So some years ago, Andhra Pradesh, for instance, came up with an insurance scheme, publicly funded insurance scheme, which covered 85% of the population, and it seemed to work for 2-3 years. Now, I don't know whether that system is still working. Have you, Dr. Reddy, studied different states, and have you the interstate comparison? Because India is like European Union, right? We could be like 20 different countries. So How do you read that?
Well, actually, many of the states copied the Arogyasri scheme, which Andhra Pradesh started. Whether it was Tamil Nadu or Karnataka or Rajasthan, Maharashtra, they came up with their own versions of that scheme.
Okay. Tell us briefly what that scheme is like.
Well, as far as the original Arogyasri scheme, which now has been called the NTR Arogya Seva in Andhra Pradesh, that scheme only looked at provision of advanced medical care in hospitalized settings to poor people, but then they included other vulnerable sections, and as you said, they ended up having about 85% of the people as eligible. They provided up to 1,50,000 rupees per family per coverage. So even things like cardiac surgery and others could be covered in private hospitals. But again, there was a total disconnect between primary and secondary care with this tertiary care scheme. And a lot of funds were flowing into private hospitals. Government hospitals were not benefiting initially. But more importantly, a lot of funds were going from the health budget, which should have gone to primary care. So they started.
So even there was a disconnect between tertiary and primary.
There was total disconnect.
There's no integrated scheme.
Absolutely. And that is why now they're also having a relook at it. Secondly,
but it's working still.
It is working. It's been renamed, but they're looking at revising it. They called it NTR Arogya Seva now. They no longer call it Rajiv Arogya Shri. Okay. It's a different name.
But that's political.
But they're also reviewing it because they also recognize this problem of a disconnect from primary health care. Okay. And the other problem, of course, is that in many of these schemes, there has been really no connect with the central scheme of RSBY as well. So we now need a merger of all of these schemes and to create a platform. One of the important elements of universal health coverage is also portability. If I am an Indian sitting in Tamil Nadu or in Telangana and I am going for employment to Delhi or Haryana, then I ought to be able to have that portability of assurance. So in order to create a national platform, the center and states will have to dialogue and create one single scheme, which can have statewide variations, it can have district-wide variations. In fact, at the district level, you can work out what kind of network should be created to provide this kind of continuum of care, using both public sector facilities, which should be strengthened, and accredited private sector, which also becomes a part of the scheme.
Dean, I want to ask you about the price of drugs, generics. In India, it's a big controversy. It's actually very political that generics, which are produced in India, which are off patents, billions of dollars of generic drugs came off patent some years ago, as you know, being made by the US and European pharma companies, and they are being provided cheap to poor people here. Now there's a lot of pressure coming from the pharmaceutical lobby in the US and in Europe, which was also part of the Obama Modi discussion. And the pharma companies, they want to do some very marginal or nominal innovation of dosages, and they want to keep their patents alive and sell costlier drugs. Now this is an issue, major issue between India and the West. Now, how do you see this getting resolved? Because the Indian position is very clear that we will not change our patent laws, and compulsory licensing of drugs will happen if there's an epidemic, or if drugs are to be supplied on a mass scale in the event of a health crisis. So, do you think these issues would come in the way of a kind of global compact on healthcare between the West and countries like India and China?
Well, I see them as part of continuing trade negotiations and intellectual property negotiations, less a matter of health negotiations. When I think of a company like Cipla here and the role that it's played outside of India in providing drugs to deal with the AIDS epidemic in Africa, and the fact that there was the technical competence and the institutional environment here that allowed that capacity to remain and that capacity to be used outside of India as well, certainly as India, it would seem to me a grave mistake for the world as well as for India, for the Indian government to relinquish kind of patent environment that it now has. And my guess, I'm not a student of trade negotiations, my guess is that will cause friction.
It'll cause friction.
It'll cause friction. And so what?
So how do you look at this problem? Because, you know, as you said, outpatient costs, drugs are a major component of the costs. And how can India protect its patent regime in order to be able to continue to provide cheap drugs to the poor people?
Well, I think what the Indian government has rightly done is to ensure that this evergreening practice of making very minor modifications without any substantive change in the nature of the drug or its action, which people in the West and the multinationals have been trying to extend their patents through, is not permitted. Secondly, they have also judiciously taken recourse to compulsory licensing when required.
I think we did it once in 2013 for swine flu, right?
For an anti-cancer drug also.
Oh, so anti-cancer.
We did it for an anti-cancer drug, which is horrendously expensive.
That's what is worrying the multinational pharma companies.
But it is good that we did it. Firstly, it affirmed our right. After all, if Canada, with a threat of anthrax, could undertake compulsory licensing with a minimal threat, there is no reason why we cannot actually undertake compulsory licensing to save very valuable
So you say on this India should not compromise at all?
I don't think India should compromise. By taking a firm stand, I mean, we are respecting intellectual property, but we are also using the Doha Declaration as it should be.
Yeah.
But by taking this kind of a firm stand, we are also driving down multinational companies to undertake tiered pricing. Okay. Many of them are now selling drugs at a lower price in India than they would be doing in the West.
Okay.
So it is very important that we take this stand to bring about affordable drugs. At the same time, we must also ensure judicious price controls of even so-called branded generics in India, because quite often the markups are too high. And for that we need pooled public procurement, so that we can actually obtain them directly from the manufacturer at a low cost and then distribute them through our public system at a much lower cost, avoiding all these markups. It's a travesty that the branded generics produced in India are sold at a higher price in India than in Sri Lanka.
Okay. So that's the real travesty. Yeah. So how do you resolve this? I mean, what solution would you recommend on this?
I think the governmental policy is appropriate, that they should say that we are following the WTO commitments, but when it comes to question of life-saving drugs, we will reserve our right for compulsory licensing in a very judicious manner, but at the same time we will not allow undue extension of patents for drugs which are going off patent, and they must support the Indian generic drug industry, but also ensure quality control.
Quality control, yeah. Now coming back to primary health care, the draft report, National Health Policy, the draft policy says that India is very close to achieving the Millennium Development Goal on maternal mortality and child mortality under 5 years. Now, how do you see that? I hear varying views. One is that we are not anywhere near achieving the Millennium Development Goals 2015. The government report says that we are pretty close to doing it. How do you see that, Dr. Reddy?
Well, as far as under 5 child mortality is concerned, we are very close to achieving it.
What is the target?
The target is 42.
42 per 100,000?
Per 100,000 live births.
Okay.
Per thousand.
Per 1,000?
No, child mortality is per 1,000.
Sorry, yeah. Okay.
Maternal mortality is per 100,000.
Per 100,000, yeah.
So now we, as far as infant mortality is concerned, which is within the first year of life, that is where we are likely to fall short, particularly because of a high rate of neonatal mortality in the first month of life. And even there, the first 48 hours are very critical. We lose a lot of babies in that first 48 hours. And that also is very closely linked to our losing mothers, where our goal is 140 maternal deaths per 100,000 live births for the maternal mortality ratio. But we are likely to fall a little bit short of the maternal mortality as well. So, however, for me the more meaningful target is not 2015 right now, because we are almost there.
We are almost there.
And we have had a reasonable acceleration of decline in the last few years. For me, it would be the 12th 5-year plan goal for 2017, which is a maternal mortality ratio of 100 and an infant mortality rate of 25. Can we reach there in the next 2 years if we actually retain this accelerated decline? So I would be really looking at that timeline.
So Dean, when you see different countries from your vantage point at your university, how do you see India's progress in terms of dealing with the maternal mortality and child mortality, the speed of reduction? Are you impressed with it?
Moderately so, particularly in recent years. Dr. Reddy and I both had the opportunity to serve on a commission, a Lancet Commission on Investing in Health, that was chaired by former U.S. Treasury Secretary Larry Summers. And Summers' interest in this is around a lot of the economic issues. We did try to take a fairly broad comparative look both at what countries had achieved. Many countries have done much better, as you know, than India.
Many countries in the among emerging economies? Much better than India.
Bangladesh, Nepal, leave aside Sri Lanka, Bangladesh and Nepal have done better than us.
Much better than us, yeah.
And how good a comparison, I don't know, but China, at a time when its income level was a fifth of India's today, had a under 5 mortality rate that was substantially lower than China. So
you're saying that China, even at lower income than India, had a much better mortality rate?
Unquestionably so, which is an interesting point for policy. How much is income important? Probably not that much. It's getting policies right, getting policies implemented.
Okay, the institutions right here.
Yeah, just on that point.
China really took care of their health policy much better than India.
Firstly, China, before the liberalization, invested a fair amount in water, sanitation, nutrition, which were absolutely fundamental for health. They also ensured equitable access to health services. There was some destabilization of their health system after very rapid liberalization, but now they're trying to set that right.
They had barefoot doctors going to villages those days,
coming back,
the 70s. Yeah.
That's right. Coming back to India, if you look at institutional deliveries, they have gone up with a variety of incentives, including the Janne Suraksha Yojana.
Yeah.
However, an analysis done about 2 years ago showed that did not have an impact on maternal mortality. The reason is you may bring people to hospitals, but unless you can assure quality of care, you are not going to make a change. So that element is the missing element, where we need more health workers, more competent health workers, better infrastructure.
So it comes down to quality of delivery, as in the case of education. Yeah.
Yes.
So thank you very much for talking to us, Dr. Srinath Reddy and Professor Dean Jamison. That's all we have in this edition of State of the Economy. We'll be back with you next week. Thanks for watching.